Hello, good evening, everyone, and welcome to 365 Live. My name is Kamin, and I will be the host for tonight's live session. 365 Live is a platform where we educate the public on cancer and encourage a cancer prevention lifestyle. Whenever you see this logo, you'll know that 365 Cancer Prevention Society is currently having a live broadcast. Tonight's talk on colorectal cancer, prevention is better than cure, is specially brought to you by 365 Cancer Prevention Society and our esteemed partner, Dr. Eugene Yeo, General and Colorectal Surgeon in private practice based in Mount Elizabeth Hospital. 365 Cancer Prevention Society has been committed to serving the community through holistic cancer prevention measures since 2003. This is accomplished through health and nutrition education, promotion of healthy lifestyle, and our 365 rhythmic stretching exercise. We also provide practical and emotional support and care for our clients and their family members in their battle against cancer through our residential and hospital visitations, counseling services, nutrition consultation, and wellness services. So please like, share, and comment on all our social media pages for the latest updates on our events and activities. The 365 CPS has been championing early detection. That's why we have introduced My First Screenings, a series of screening campaigns that empowers individuals to proactively take steps towards early detection and a healthier future. Unfortunately, not everyone has access to these essential screenings due to financial constraints. Help us bridge this gap. Right now, we are facing a critical shortage of funds. If you're keen to support these initiatives and fund screenings, feel free to take out your phones and scan the QR code to donate. I'll give you a few moments to do so. Do donate generously, as a donation will go a long way in helping a child, parent, or caregiver around you receive the treatment and support they will need. I'll also like to take this time to remind you that all information shared at this event by the speaker and 365 CPS are general information only and subject to changes. Do consult your doctor for personalized and detailed medical advice. So, without further ado, it is my absolute pleasure to introduce tonight's speaker, Dr. Eugene Yeo, General and Colorectal Surgeon in private practice based in Mount Elizabeth Hospital. Prior to that, Dr. Eugene Yeo trained and practiced in Singapore General Hospital for 17 years, and he is a strong proponent of colorectal cancer prevention and treatment. He will be sharing on the topic of colorectal cancer. Prevention is better than cure. If you have any questions, feel free to post yours in the chat below, and we will address your questions during the Q&A session. Hello, Dr. Yeo. Thank you so much for joining us tonight to share your knowledge with everyone here. Let me hand over the time to you now, Dr. Yeo. Thank you.
Okay, thank you, Carmen, and thanks to 365 for inviting me to give this talk. This is something I'm quite passionate about because over the last many years that I've been working both in the public and the private sector, we do see quite a lot of colorectal cancer patients, and I will explain a bit more that it's really quite the most common cancer in Singapore. In fact, the most common. There's many things that we actually can do to prevent it. And I would like to go through with everyone so that we can help to reduce the incidence of colorectal cancer in Singapore. Thanks to everyone for coming tonight. I know it's a Saturday night, but glad to have you with us in our quest to prevent cancer. All right, so I'm going to start. Prevention is better than cure. This is generally true, all the more so for cancer. First warning is that I'm going to be showing some photos, slides, and even videos that show some tumor cells, some polyps, some cancers. So if it is disturbing to you, you may want to look away or maybe not look, but just listen to the content. So as an introduction, I would like to say that year on year, this is Singapore statistics, the number of cancer diagnoses have gone up and it's looking like it's going exponentially. You can see in the 1970s, it's about 20 to 30,000, and then it's gone up to almost 70,000, or in fact, reached 70,000 in the 2020s. And this is the number of single diagnosed cases per year. And out of the causes of death in Singapore currently, cancer is the top cause of death. Almost 30% of all deaths are caused by cancer in Singapore. This is a numerical representation of that data, and you can see both 2020, 21, 22, even 2023, cancer was the leading cause of death locally. What are the common cancers in Singapore? The most common tend to be these that I'm showing on the screen: breast cancer for the ladies, prostate cancer for the guys, colorectal cancer, which I'm going to talk about today. The other common cancers include lung cancer, ovarian, endometrial, which is the uterus cancer, as well as liver cancer. But how common are each of these? So if we look at the breakdown between males and females, in the number one spot for the males is actually colorectal. In the number one spot for the females is breast, but colorectal comes very close behind at number 2. So in Singapore, colorectal cancer is actually the most common cancer that we see and diagnose. Fortunately, it's not the highest mortality cancer, but it's still the most common cancer. And it certainly does contribute to quite a lot of suffering and also mortality. So we do want to reduce its incidence as much as possible. A few facts about colorectal cancer. The sad thing that I see in my practice is that colorectal cancer is actually most commonly diagnosed at the later stage. If you look at these graphs between males on the left and females on the right, the highest percentage of cases that are diagnosed, that colorectal cancer is diagnosed at, is actually stage 3. And if you look at stage 3 and 4, which are considered theoretically the later stages of cancers, more than 50%, more than half of colorectal cancer patients are diagnosed at the later stages, when we could actually screen, prevent for it, and reduce this amount if we do the right things. And what's the problem with being diagnosed later? Well, the later you get diagnosed, the worse the prognosis is, or the worse the survival is, which means if you get diagnosed at stage 1, for example, your survival within the next 5 years, if you get treated, is 90% or so for colorectal cancer. But if you get diagnosed at the later stages, stage 3 and 4, you can see the chance of a patient surviving beyond 5 years is getting less and less, and it gets less and less very quickly. Once you reach stage 4, it's less than 25%. I mean, of course, the percentages have slowly come up slightly over the years because our treatment is better. We are finding better therapies, but still, you don't want to get into a place where you get diagnosed late. So earlier the diagnosis, the better for all the patients and also for the doctors, so we don't have to do such radical treatments. So I'm going to talk about colorectal cancer in a bit more detail now. This is the summary of the contents of my talk, and I will just proceed. So what is colorectal cancer? First, you need to understand what is the colon and the rectum. And the colon and the rectum, if you look at this diagram, is the lower part of the intestinal tract. When you eat food, it goes into the stomach, the liver, gallbladder, pancreas help the food to digest. The food gets absorbed in the small intestine, and subsequently the waste product goes into the large intestine, which is the colon. And the rectum is the storage organ where all the stool gets stored before it gets pushed out via the anus. And this is the area where colorectal cancer, as the name suggests, develops. And where in the colon does colorectal cancer tend to happen? If you look at the statistics, and this is what we see in practice as well, the lower part of the intestine, on the left side, the sigmoid and the rectum, tends to be the most common areas where cancer starts to develop. On the right side, this is the patient's right, about 1/3 of the cases, and then the rest are somewhere in the middle. But most importantly, the lower part of the rectum and the sigmoid is the area where the cancers tend to occur most commonly. How does this cancer develop? Does it just appear out of nowhere? Is it because you are born with it? Well, the answer is no. The answer is actually colorectal cancer. In the large majority of cases, they develop from something that is benign. So they develop from this thing called polyps. What are polyps? Polyps are actually small little growths. Think of them as a small little lumps in the wall of the colon. And these lumps will start small and they will slowly grow bigger and bigger over time. And as they grow bigger and bigger, they can develop certain mutations that can lead to the cells starting to grow more and more uncontrollably. And once it becomes to the stage where the cells are completely uncontrolled in their growth, that is when it invades the rest of the colonic wall and then become cancer. So it always starts with a small polyp. And here is where the important idea lies. If we can find the polyp at the early stage and we remove that polyp, it will never be able to develop these invasive cells that can cause cancer, which is why colorectal cancer is imminently preventable. And I really, really think that more people should be aware of this and consider getting screened at an earlier age. So how long does the polyp take, right, to become from the normal colon to become a cancer? Essentially, it takes about 5 to 10 years. So that's quite a long time. How does it develop? Like I mentioned, it usually starts with a few mutations as the cells start dividing, and then the mutations slowly add on top of the early mutations. And eventually, once there are enough mutations in the cells, they eventually become cancers. But this process takes many replications of the cells, which is why it takes typically about 5 to 10 year duration, during which we can actually prevent the cancer from turning up and becoming an actual cancer and needing treatment. So when you get cancer, what are your symptoms? How do you know you have cancer? Unfortunately, when it comes to colorectal cancer, many are asymptomatic, especially the early cancers. But of course, the location, the stage, and the size of the tumor is the main dependent on whether the symptoms occur early or late, or even if there are symptoms at all. But again, early cancers are asymptomatic most of the time. Example is this very early, is quite an early cancer, but it's a very large polyp. In the patient that I scoped a couple of years ago, we removed the polyp and it turned out to be an early cancer, but the patient had totally no symptoms at all. He just came because he was in his 50s and wanted some screening, and we found this. Right, so you cannot rely on having symptoms to go to the doctor, especially when it comes to screening. The whole idea of screening is to catch something before it becomes a problem, right? And you don't want it to turn into cancer. You want to catch it at the polyp stage before it develops into cancer. But if you do have symptoms, what are the symptoms that tend to occur? Well, I divide them into generally 3 different groups. The first group is the symptoms that changes in the stool. So you get rectal bleeding, you get blood in the toilet bowl, you get blood in the stool, you get your stool getting narrowed, you get some diarrhea or constipation, right? Other symptoms include symptoms of abdominal discomfort. You get abdominal pain, you feel that after you pass motion, you still have some discomfort, you feel there's something left inside, right? These are possible symptoms. The last group of symptoms are generalized symptoms where you feel weak, you feel tired all the time, and you get an unexplained weight loss. So all these are symptoms that can suggest or can occur from colorectal cancer. But again, majority of cancers or colorectal cancers are asymptomatic. So how do we diagnose it? Once you have the symptoms, you want to go and see a doctor. There are many people who think that you can do a stool test to diagnose cancer, but the truth is, unfortunately, no. Some people think we can do a CT scan or MRI scan or a special X-ray that we can find cancer. And the answer is no, you cannot definitively diagnose cancer with a CT scan. The only way to be sure and to be definite in your diagnosis of colorectal cancer is actually a colonoscopy, which is essentially is putting a camera under sedation, so patients are well sedated and asleep and very comfortable. We put a camera through the entire anus, rectum, and the colon to have a look and see inside if there are any polyps, any growths, and we deal with them and we can biopsy them, which I'll show you later. So how it's done with bowel preparation. So there is some requirement to clear the bowel. If not, it's too dirty, we can't see anything. We give some sedation so the patient is very well comfortable and having a good sleep. And then we start doing the scope. The patient is lying on the side, and then the doctor will go in, put the scope through the anus, and then scope the entire large intestine. Bowel preparation before the scope, for those who are going for scope or thinking of going for scope, is very important, because if you can see if there's good bowel preparation, this is what the toilet bowl will look like when you flush it all out. And then in the colon, we can see very clearly the walls, and it's unlikely to miss anything. But of course, if you have bad bowel preparation, in fact, this is not the worst we've seen. We've seen some with solid, large stool in there. You can imagine how we can miss a small polyp like this, right, on the scope, because if there's too much, there's too much stool, we can't see, right? And so bad bowel prep can hide polyps. So if anyone does go for a colonoscopy, please do make sure you make the bowel prep is clean. If whatever medicine that was given to you to drink it still doesn't clear it, then please drink more water and make sure that the toilet bowl should look like this after you finish. So these are small little polyps that are early stage of the growths that have not turned to cancer yet. And these are very easily removed. These on the scope are bigger polyps, as you can see. These polyps still can be removed. Some of them may be early cancer. Majority of them still are not cancer yet. So this is still a time, maybe at the 4-year mark or 5-year mark, where they've grown to this size, still can be removed without requiring cancer treatment per se. But once we see something like this, these are large polyps or even growths that invade the wall already. You can see this. These have turned to cancer already. But of course, we do need biopsies to confirm this. But this is where we don't want to find the state of the polyp in. So how do we diagnose it? After we see on the scope, what we do is we take biopsies. That is why the scope is the only way to find out whether this is cancer or not. So when we take biopsies, we take little pieces of meat from the polyp or the tumor, and we send it to the lab. And the lab looks at it under the microscope and sees whether the cells are normal or abnormal. On the left side, you can see that these cells are normal, very, very well differentiated. You can see the different layers of the wall. But you can see on the right, this is a cancer cell that you look under the microscope. This is a wall. And the wall is no longer has these nice different layers. You can see they're all merged into one, because these cells, these are the abnormal cells, have started to invade the wall. So this on a slide is the thing that helps us to diagnose whether the cancer is present or not. So after we diagnose cancer, we need to stage it, and there are various stages of the cancer. Essentially, you don't want it to find it at stage 4, but it basically means that the more advanced the cancer is, the higher the stage it becomes. And at stage 4, it has spread to the other organs. Once it's spread to the other organs, it's very hard to cure, which is why the 5-year survival tends to be much lower. So how do we stage a cancer when we have found one on a scan? We do CT scans. So most patients, once they get diagnosed with a tumor or cancer, we do CT scans to make sure it hasn't gone to the liver or the lung. These are the two most common places. On the left is a picture of the liver, where you can see the tumors have grown in the liver. Normal liver should look like this on the light color, but all these dark little spots are tumor spread. And of course, this is the lung, and the lung also has normal lung tissue should be dark and black, right? Because there's a lot of air in the lung, but all these small little solid nodules are all cancer spread. And of course, we also need to remove the cancer as part of the staging, because as part of the staging, we need to assess the lymph nodes, which are little glands that are next to the intestine itself. So this is a sample of the intestine that we have removed during surgery. And all the lymph nodes are in the fat here next to the bowel. And this is where we do a count of the lymph nodes and see how many lymph nodes are affected. And if the lymph nodes are affected, it will change the stage, right? So surgery is also part actually of staging and also treatment of colorectal cancer. Once we found colorectal cancer, what do? We need to treat it. Treatment is a combination or various combinations of surgery, chemotherapy, and radiotherapy. I'll go through this very quickly. Surgery essentially is the primary treatment for colorectal cancer. It involves removing the part of the colon with the tumor, as I have shown before this. And after we remove the bowel, we need to connect it back again. If not, we cannot continue to pass motion in the normal manner. And of course, we can do surgery in many ways. I'm very interested in the keyhole or robotic approach, but that's not the topic of our presentation today. Open surgery is the traditional surgery where we make a big cut in the abdomen, and from this big cut, we put our hands in and we remove the tumor out. And of course, with a big cut, you get a large scar at the end. As technology progresses, we can do it now laparoscopically, which is keyhole. Keyhole surgery means we put a few small little pots on the abdomen, blow it up with carbon dioxide, and from there we do the surgery and remove the colon with a much smaller incision. With the smaller incision comes faster recovery, less pain, less risk of wound infection. So that's the advantage of keyhole. And keyhole if you compare the previous scar to this one, you can see that the keyhole scars are so much smaller and a lot more cosmetically pleasing. But more importantly, smaller scars also mean faster recovery, less time in the hospital, faster return to work, and faster return to normal activities. And of course, the most up-to-date or the most high technology form of surgery at this point is what we call robotic surgery. Robotic surgery is something like laparoscopic surgery where we put pods on the abdomen, but instead of holding the instruments through to do the surgery, we have a robot that is attached to the patient that helps us to control the instruments. But the surgeon still controls the robot in a console at the side. So what we do is we sit at the console, we use the console to move the robot, and the robot does the surgery. And the advantage of the robotic system is that we have three-dimensional vision. We have tools that we are not able to use in laparoscopic surgery, and our instruments are like the wrist, so the instrument can move with like a full wristed motion. So we get a much better range of movement in a small area for the surgical surgery to be done. Other than surgery, there's also chemotherapy. Usually this is given as a complement. We give it systemically, which means into the blood. Most of the time through a vein. Sometimes it can be given orally. And chemotherapy is essentially a toxic metabolite, right? It's something, a poison for cancer cells because they affect cells that divide quickly, which cancer cells do. But however, this may also affect the normal cells, which lead to some side effects of the chemotherapy. But of course, there's now advances in chemotherapy, and other types of chemotherapy actually allow more specific attacks to cancer cells, which reduce the side effects to patients. Radiotherapy is another complement. We usually use this in rectal cancer treatment, in colorectal cancer. So we give high dose radiation to the tumors, which cause tumor to die. But because we attack the tumor in that location, the organs around it may have issues subsequently. For example, when we do radiation for the rectum to do for rectal cancer, sometimes patients can have bladder problems next time because of the radiation effect in the long term. So that is generally the treatment for colorectal cancer. So most importantly, actually, I've kept to the last, which is what is the risk factors of cancer and how do we prevent colorectal cancer? Because we don't want to get to the stage where we need to do surgery or have chemotherapy or radiotherapy. Risk factors are generally split into two halves. One of them we call unmodifiable, which is you are born with it, you can't change it. But the more important one is actually modifiable. I will go through the unmodifiable ones first to be complete. Unmodifiable age. The older you are, the higher chance you have of getting cancer. So the general age in the past used to be 50 years old. So at the age of 50, you are much higher risk, or you have significantly higher risk of developing colorectal cancer, or not just colorectal, but many other cancers as well. So that is the time traditionally where we ask patients to start going for screening. However, we have found over the last decade, 20 years, the last 1 to 2 decades, we have noticed there has been an increasing incidence of colorectal cancer in young patients. And since 1994, about 2% per year are getting cancer below the age of 50. And you can see that rectal cancer has increased significantly in proportion, and colon cancer as well among the younger patients. And this patient, there was an article on him, this was some time ago, about a decade ago. He developed colorectal cancer at the age of 26, right? So these are probably genetically related, but certainly age is one factor that affects your risk. And because of this, the United States have decreased their cancer screening age from 50 to 45. And this happened quite recently, about 2-3 years ago. Not all the world has changed yet, and I suspect this is probably because of logistics and health economic reasons. But we definitely are seeing more and more patients getting cancer earlier. So as an individual, you might want to consider not waiting till 50, but perhaps earlier to start looking and to start evaluating yourself, or asking your family to get themselves checked. How about family history? How does family history affect colorectal cancer? Well, essentially, each relative you have that is a first degree literally doubles your risk. So if you have no family members with colorectal cancer, your risk is the same as the population. If you have one, your risk is doubled to 2 times. If you have 2 family members, your risk is quadrupled, 4 times, right? And if you have 3, it becomes 8 times. So each first degree relative, mother, father, brother, they double your risk of having cancer. So it's very important in those patients with a family history to also get screened. And other history would include other things that you cannot modify, include other medical problems, such as if you have previous polyps, if you have a genetic syndrome that predisposes you to develop cancer, that one you're born with, you have no choice. You just have to go for screening regularly. But most of us don't have this. So now, most importantly, we need to tackle what can be modified, what we can do to help to reduce the risk of colorectal cancer. So I'll go through each one of these quickly, and then so that everyone can understand a bit more. So first is diet. Diet, there are 2 things that have been well studied to reduce the risk or associated with risk of colorectal cancer. First is red meat and processed meats. We know that red meat and processed meat do have a very high association, and in fact it's been classified as a carcinogen, especially the processed meat, sausages, salami, bacon, above a certain amount, because they are associated with a significant increase in risk of cancer compared to low intake. So if you take a lot of red meat compared with someone who takes very little, there is a risk. It doesn't mean you shouldn't take, right? It's a good source of iron and all that, but you should not take so much that you increase your risk. And why do red meats and processed meats cause increased risk? It is because the breakdown of all these products, okay, it is very complicated, but essentially creates this compound called NOCs, right? Nitrosilate compounds. And these cause DNA damage. And remember, I explained as the polyp turns from a polyp into a cancer, it is because the DNA is mutated. And this DNA damage facilitates, or it makes the DNA mutate faster, right? And that's why it increases your risk of developing cancer. On the other hand, we have also found that good fiber intake, that means those people that eat a lot of fruits and vegetables, does reduce the risk of having cancer up to about 40 grams of fiber a day. That probably translates to about 1.5 to 2 servings of fruits and vegetables per meal. We can see these are essentially it's a statistical tool, but anything to the left means it's better, anything to the right means it's worse. All the different studies done over the years show that most of the studies show that it is better to take more fiber rather than less fiber. What else? Exercise. Okay, exercise is something that I think all of us know to do. It's good for the heart, it's good for the cholesterol, it's good for your lung capacity, it's good for your bones, right? But it's also good to decrease the risk of cancer. And this has been found in many studies as well. What's the recommendation? 150 minutes a week is the general recommendation. If you can do more, it's always better. Even if you don't do sports or go to the gym, just get active. Go for a walk, take a slow jog, go out with the children or the kids, right? Walk your dog, right? All of this is some exercise, and any exercise is better than none. So we know that exercise reduces our risk of developing colorectal cancer amongst others. And why does it? Because it's highly linked with obesity. We know obesity can increase colorectal cancer depending on what the BMI is, right? The cancer risk can increase by up to twice. And obesity is not just like exercise, it's not only linked to colorectal cancer alone, but it's linked to so many other cancers, which would increase in risk if patients are obese. And this has all been proven in multiple studies. So exercise helps with obesity, which in turn reduces the risk of colorectal cancer and other cancers. This is a no-brainer. Everyone knows this. Here I'm just going to show you to quantify it. 1 pack a day increases your risk by 50%. And heavy drinking, which is 4 standard drinks for women or 5 standard drinks a day for men, also increase it by 50%. So don't smoke, try not to drink. Yeah, that's the message here. And finally, and probably the most important, is what screening can do. As you understand from the earlier part of my talk, screening, the idea of screening is actually to look not for cancer, you want to look for the polyps, right? So if you look for the polyp, you remove the polyp, and that will essentially remove the risk of developing cancer subsequently. So there are 2 methods of screening generally. The first method is what we call the stool test. This is the easy one in the sense that we send the stool for blood, right? For patients who have no symptoms, we send the stool for microscopic blood after it's assessed. And if there is blood in the stool, the concern is whether there are polyps or growths inside the colon that could be cancer. Then these patients are sent for a colonoscopy, and the colonoscopy can evaluate further. So, of course, colonoscopy is the gold standard for screening. And we can see that stool tests, it is effective to a certain level, but colonoscopy is significantly more effective in reducing the risk of developing cancer and cancer death. And again, the recommendation for cancer screening, colorectal, would be between 45 to 50 years old. So I'm going to finish off with a video. So those of you that are grossed out by images, please don't watch this, but I do want to show how we do a colonoscopy and what we do when we find polyps, right? So this is a video of a colonoscopy, right? This is one, all of them are mine. So this is the smaller the polyp you can see. And this is how we remove a polyp. The scope has an aperture where we can put an instrument in. And with the instrument, this is called a biopsy forceps, we can remove the polyp by grabbing it, and we burn a bit of the base. You see that? Now we run the current through, burn the base, and remove the polyp. So this is how we remove it. And the small one is easily removed. What happens if it's bigger? Right? So in the case where this is a bigger polyp, right? It has developed. Maybe this has been around for 3-4 years. We don't know. But what we do is we can still remove it, although a bit more complex, right? What I do is we inject it, and we inject to raise it up. And why do we raise it up? It's because we don't want to injure the wall of the colon. And after we've raised it up, we will put what we call a snare, or it's like a lasso. It's a metal snare, and we use it to catch a hook onto the polyp, right? And you can see as we tighten the lasso, the polyp will get caught inside, and subsequently, because it's metal, we run a current through and we burn through the tip, and that's how we remove the polyp. And this tip potentially can bleed, so I always, you can see there's some blood here, so I always put a clip here to stop the bleeding or to prevent further bleeding. The clips, if you're interested, they will drop off, right, eventually, but we do that in the short term to reduce the risk. So this is an even more advanced polyp. You can see it's starting to look a bit ugly, right? This is definitely more advanced than the previous one. In fact, this is probably early cancer already, right? And so this again is a snare. We're doing the same thing, and we cut through with an electric lasso, right? We call this an electric snare. As you can see, I cut it through. Right? So how do we remove these polyps from the colon? It is too big to be sucked from the tube. So what we usually like to do is we like to use another instrument. We call it a net, right? So we remove it like similarly to the snaring. We put a net in, and the net is like a lasso as well. So the metal is still here, but it's got a net. So yeah, there's some techniques we need to learn to figure out how to remove it. Essentially, what you do is you wrap it up, right? And then we pull it out through the bottom. And that's how we remove these larger polyps, because they cannot be removed through the scope, right? They cannot be removed through suction through the scope because they're too large. So you can see this being pulled out, and that's how we get it. After we remove the polyps and we clip them, in some cases, in this case, where we're worried that there's cancer, or in fact, I think it's probably going to be cancer already, I will usually tattoo the area. What is a tattoo? Tattoo is essentially a marking of the area, so that if we do find out that eventually this is cancer, then we can find this location, right, during surgery, and we can remove it. And this injection here is a carbon. It's a carbon compound, and it turns the entire colon black so that we can see it well. And of course, this is the final stage where it's already cancer. It is too large to remove, as you can see. Trying to remove this will cause an injury to the intestine, and then the patient will get a very bad infection. So these will require surgery already, right? Unfortunately, but we are also going to take some biopsies through this because we need the tissue to confirm that this cancer, and this patient had to go for surgery subsequently. Okay, so I'm done with my talk. I'm going to summarize, and then we can go to the Q&A if there are any. Colorectal cancer is the most common in Singapore, and most important message of my talk is they develop from polyps, and if the polyps are removed, the cancers can be prevented, which means you don't get cancer at all. You need to diagnose and stage with colonoscopy and CT scans, and the treatment, if you get diagnosed with cancer, would depend on the stage, of course, and may comprise of a combination of surgery, chemotherapy, radiotherapy, but we really don't want to get to there. Other take-home point is that many risk factors are modifiable, which means you can reduce the risk with your own efforts and leading healthy habits. And of course, the most important that I want the point I want to bring across is please perform screening regularly if you're of age, if you have family history of colorectal cancer, if you have symptoms that are suggestive or you're worried, or if you have polyps before, right, make sure you go for a regular screening to prevent cancer from developing in the first place. And that's the end of my talk. Thank you very much.
Thank you, Dr. Yeo, for your comprehensive and informative sharing. So indeed, prevention is better than cure. So let's all proactively take steps towards early detection and a healthier future. So I hope everyone has learned something more about colorectal cancer and its prevention. So if anyone has any questions, feel free to share them in the chat and we will address them accordingly. So now we will take some questions from the floor. I see that we have a few questions from the audience. So Wong VW asks, Dr. Yeo, is sedation same as general anesthesia?
Okay, that's a good question. That's the same question that many patients ask me. So sedation is not the same as general anesthesia, but sedation is on a continuum to general anesthesia. So usually what general anesthesia means is that a patient is paralyzed and completely sedated. That means they're given medication not only to sleep, to decrease their consciousness, but also to paralyze their muscles. This state is required during surgery because we don't want a patient to move during surgery. But because the patient is paralyzed, we do need to put a tube in to help them breathe because they're not able to breathe on their own. So that is considered as general anesthesia. Sedation, on the other hand, does not require paralysis of the patient at all. Right? This is usually done in the less what you call invasive type of procedures, such as colonoscopy or any other kind of scopes, where you don't need the patient to be completely still. Patients can still move a little bit, but you sedate them so that they are comfortable and they don't have any sense of that the procedure is going on. Because actually during the procedure, there's very little pain per se, but the sedation just helps them to relax and make the whole procedure a lot more comfortable for both the patient as well as the doctor that's doing it, right? So that's the difference. It's the depth of how much you kind of make the patient unable to move or to be conscious. And of course, the deeper you go, it takes much longer to recover from. Right? So if you go into general anesthesia, it takes much longer to recover back to consciousness than if you take sedation. So again, we don't want to waste everybody's time when it's not necessary, right, to go into general anesthesia. So for most scopes, we do it under sedation But sometimes, in some cases where the patients are really very anxious or there are some issues that general anesthesia is better, we may put them under general anesthesia, although that is very rare. I hope that answers your question.
Okay. Following next, we have a second question by Elaine Lim. So she asks, after chemo, is it necessary to go for surgery?
This question is a bit difficult to answer straight up because each patient is really different and it depends on, I'm assuming we're talking about colorectal cancer. It depends on the stage of the tumor, whether there is any tumor spread. In some cases where the tumor has spread, chemotherapy can be given as a first line to control the tumor and subsequently go for surgery. So it is possible that that is the correct sequence of treatment, but it really depends on the individual patient themselves and what they are suffering and what condition they have. So this will probably be best discussed with the doctors that are treating the patient. If I don't have the details, it's very hard for me to comment as to whether it is necessary or not. But certainly chemo first and then surgery is one of the ways that we do kind of sequence the treatment for colorectal cancer. I hope that's good enough.
Okay, thank you, Dr. Yeo. So we have another question by Gary Ong. He actually has a very long comment
Okay.
here. So he's actually asking for your advice. So
I
he
see.
actually did colonoscopy done on February
Great.
2022. So
Okay.
I think he mentioned that there is a diverticulum in cecum, sigmoid, and
Cecum.
cecum,
Okay.
sorry,
Yes.
cecums,
Yes.
and ascending colon, polyps in ascending colon.
Right.
So
Right.
FOBT 1 positive and 1 negative in February 2024. So the medical officer said to redo colonoscopy in 3 years despite one FOBT
Yes.
positive
Yes.
colonoscopy in
Yes.
February
Okay.
2022. So do you agree to wait till February 2025 to repeat colonoscopy?
Okay, so if you understand what I was speaking about earlier, I explained that the idea of the FOBT or fecal occult blood test is to test for microscopic blood in the stool, which, if positive, would lead the patient to go for a colonoscopy. But the eventual gold standard of the decision of the timing of colonoscopy should be based on the colonoscopy result. So again, I'm glad that Gary went for his scope, and I'm glad they found some polyps and removed them. The time at which you do the next scope would depend very much on how many polyps there are and what kind of polyps there are. So not all polyps will turn to cancer. So it would depend on what we call the histology or the type of the polyp. So, but generally speaking, if you do have colonoscopy done already, there is actually no need to do any more fecal occult blood tests because the colonoscopy will supersede the fecal occult blood test anyway. If you understand what I mean. So the finding from the colonoscopy is more important because the colonoscopy is the one that looks for cancer, but the fecal occult blood test looks for blood. And blood is can be coming from piles, for example, or other issues that are not cancerous. But it's a good entry point to get people to go for colonoscopy. And also, it's a good screening tool because not everybody is willing or may be able to afford to first line go for colonoscopy. I hope that answers your question. So technically speaking, since you have done a colonoscopy, Gary, you don't need to do any more fecal occult blood tests. You just go for your next colonoscopy in 3 years' time.
Okay. And then we have a question from Cass Chan. She asked, where can I book a colonoscopy? So based on my understanding, I think there is a campaign by Cancer 365 CVS. So the campaign will be available for individuals with blue orange CHARS card, but there are limited slots left as the takeout has been great. So most likely they'll be bringing back the screening next year. Okay. And then we have a question from Erin Chan. If the person is already diagnosed with endometrial cancer, does it increase the chance to get another cancer?
Well, the short answer is yes. Having one cancer does increase your risk of developing another. But again, it is not, I wouldn't say that endometrial cancer specifically increases the risk of colorectal cancer, if that's your question. Yeah.
Okay, and then we have a question from Justina Go. So she says that with family history of diverticulum, the mother, so would there be risk of the children developing colorectal cancer?
Good question. Diverticular disease or diverticulum is essentially is a non-cancerous disease. It is a weakening of the wall of the colon, and this is usually related to age. As we age, you can develop this, but this doesn't increase your risk of developing cancer, and it doesn't increase the risk of the children developing cancer either. So diverticular disease is a separate disease from colorectal cancer, and it's not related to cancer at all, right? It can give other problems such as in the rare cases bleeding and infection, but most of the time it is not related to cancer directly.
Okay. And then we have a question from Jo Ong. So she asks, after a successful laparoscopy to remove a stage 3 sigmoid cancer, is it necessary to go through adjuvant chemotherapy?
Adjuvant chemotherapy. Okay, so in context, adjuvant chemotherapy means it's like a supportive treatment to continue treatment for cancer. So as I explained earlier, there are different stages of cancer. And with a higher stage, the risk of recurrence or the risk of survival decreases over time, as the stage goes up. And we have and usually above a certain stage, most of the time stage 3, there will be a recommendation to start chemotherapy. And the reason is that at the more advanced stages, there is, although surgery has removed the cancer away from the body, but there is a chance that there is tumor cells that is circulating within the bloodstream already as part of the cancer developing. The problem is that the circulating tumor cells cannot be seen by any scan, and it cannot be tested with any blood test. So we won't know, right, if whether there are any small little tumor cells that are circulating around the bloodstream waiting to grow at a later date. So in the stage 3 cancers, it means that after you remove it, when you look at it under the microscope, you can see that the lymph nodes are involved, which means that it's quite advanced. There is a reasonable chance that there are microscopic cancer cells in the bloodstream that may grow in other places in time. So chemotherapy, which is given through the veins, right, goes into the bloodstream and destroys all these little invisible tumor cells. The question is, generally speaking, right? Of course, every patient is different. Most of the time after stage 3 surgery, we would recommend consideration of chemotherapy. But again, because the risk for chemotherapy in terms of the side effects is lower than the risk of recurrence. So that's how we decide which to give. If your risk of side effects is higher than the risk of recurrence, then we don't bother to give, because then it is not worth the risk. Yeah, but so in stage 3, generally speaking, if the patient is fit and willing, we would recommend it to reduce the risk of the cancer coming back in the future. Right, but again, this depends on stage. In this case, in the question that is stage 3, we would usually recommend this. But again, it is based on the individual patients. Not all patients are fit. Not all patients are able to go through chemotherapy for various reasons.
Okay, thank you, Dr. Yo. So I think we still have 2 more questions from the ground. Okay, so Richard Liao is asking, will the hemorrhage turn into CRC?
Okay, I think he's asking about hemorrhoids, which
Hemorrhoids,
are piles, which are, colloquially we know them as piles. Hemorrhoids is the medical term. CRC is colorectal cancer. So I think his question is, do piles turn into cancer? The answer is no. Piles are benign. They will always be benign. They will not turn into cancer. And what I tell most of my patients is that piles actually don't cause any life-threatening problems, right? So you don't really have to treat piles unless they are bothering you. But The issue is that sometimes piles and colorectal cancer can present with very similar symptoms, right? And rectal bleeding, which is bleeding after passing motion, is one of them. So the piles per se doesn't turn into cancer, but piles, cancer can mimic piles, right? So if you do have bleeding and you think it's just from piles, you may want to consider getting checked anyway if it doesn't resolve, or if you're above the age that you require to be screened.
Okay, and we have a second question by Wong VW. So, for a normal person without cancer diagnosis, how often should we do colonoscopy?
Yes, thank you for the question. So colonoscopy will be done depending on the risk profile. Remember, I spoke earlier a little bit about the different things that increase your risk. So if you consider a normal person based on your question, right? Normal person means no risk, no high risk factors. That means no family history, you don't have polyps before, you don't have cancer before, you don't have any inflammatory bowel disease. Generally speaking, we would say 5 to 10 years should be a safe time to go for your colonoscopy. Depend on how kiasu you are, right? Because the studies will say between 5 to 10 years, which means that let's say we do a colonoscopy in 2020, right? If touch wood, the day after the colonoscopy, your polyp starts to grow because we didn't see any polyps during the colonoscopy, and it takes 5 to 10 years to develop into a cancer, then you see how kiasu you want to be, lah, right? If you want to be more kiasu, then you 5 years, you catch it, and then, but if you think that, okay, so the general accepted is between 5 to 10 years. That's my answer.
Okay, sure.
Of course, if you do have polyps, if you do have cancer before, then the timing, like the previous question was, sometimes we bring it forward, like 3 years or 2 years or even yearly, depending again on the condition of the patient themselves.
Okay, I think we see many audiences giving thanks to Dr. Yeo for answering the question and the explanation. So on my end, I have two questions for Dr. Yeo. So may I ask, right? So some people may think that their bowel habits are irregular. So does it mean that the person has cancer?
Okay, so bowel habit is one of these things that very difficult to quantify, because what does irregular mean? The truth is everybody's bowel habit is slightly different, because bowel habit is dependent on so many factors, depending on your gender, depending on your activity level, depending on your what you eat, depending on what medicine you're on, depending on your sometimes your weight, right? Sometimes depending on other medical conditions that you have. So what is normal to me will be different. What is normal to you and will be different from for what is normal to your parent, for example. So again, irregular, there's no quantifiable irregular that is that is standard for everybody. So more importantly for the individual is that, do you have any change in the usual way that you pass motion? For example, if you used to pass motion every 4 days, right, that can be normal for you. But if there's a change recently that you start passing every 2 days, and you know it doesn't, you've been passing every 4 days for years, and then suddenly you pass one every 2 days, then there's something you want to think about. So again, or the color has changed, or you know the quality of the stool has changed. So that is more important than the actual number of days or the actual number of times that you pass motion. Because again, everybody is different, and depending on your body, your habit, right? And if you change your habit, sometimes that can even change your bowel habits. For example, if I go overseas, a lot of patients will tell me I get constipation, which is very common because the environment changes, your body reacts to it, and sometimes it changes the way that you pass motion. Yeah, so I hope that answers the question.
Okay, thank you, Dr. Yu. So I think we have one last question tonight to round up. So it's a question by Andy Go. So he asks, if a family member has history with colorectal cancer, how often should we do colonoscopy?
Okay, again, the family member would depend on how close the family member is and how many family member. If you're talking about single family member that is maybe your first or second degree, I would generally recommend around 3 years. Of course, if you have more family members, then you may want to do it even closer. But 3 years should be a safe timing to do. But again, sometimes if you do it a few times for 3 years and then you don't find anything, not at all, sometimes the doctor may push it back to 5 to 10 years, right? So again, it depends on the individual patient. But as a general rule, 3 yearly will be a safe period if you have a family member with colorectal cancer.
Thank you, Dr. Yo. Wow, I see a lot of audience members actually leaving thanks. So thank you everyone for all your questions, and thank you, Dr. Yo, for your sharing and for answering all the questions from everyone here tonight. I wish you a wonderful Saturday evening and a Sunday ahead. Thank you, Dr. Yo. So it's now
Thank
time for
you.
Dr. Yo to take his leave. So once again, thank you very much for sharing your professional insights.
Good
Thank
night.
you. Okay, so before we close tonight's session, I would love to get some feedback from you for tonight's session. Thank you for being here tonight and for participating. We want your feedback because we want to know what we can do differently and what could have been done better. And what other topics you would like to learn from and learn more about so that we can run these events better for you. At this point, we will appreciate if you take some time to complete the feedback form for tonight's session. So kindly scan the QR code on the screen with a mobile device or click onto the URL link in the comments section to give us your feedback. So our next 365 Live will be on the topic of understanding cancer prevention and treatment from the perspective of traditional Chinese medicine. It will be a session in Mandarin on 8th June, same time as and same place here on our Facebook platform. And also, 365 CPS has been championing early detection. That's why we have introduced My First Screenings, a series of screening campaigns that empowers individuals to proactively take steps towards early detection and a healthier future. So, right now, we are also facing a critical shortage of funds. So if you are keen to support these initiatives and fund screening, feel free to take out your phone and scan the QR code below to donate. So I'll give you a few moments to do so. Do donate generously as your donation will go a long way in helping a child, parent, or caregiver around you receive the treatment and support they will need. So do like and share our social media pages for the latest updates on our events, such as this 365 Live event. So once again, thank you very much for joining us tonight. I hope to see you all in the next session. Take care, stay safe, and good night.